It's good to be here. I must confess I haven't made every meeting since that first meeting in Doral. As I look back, this has come a long way, and thanks to all of you for your involvement and participation. I am particularly pleased to be back today. It makes me feel old to be giving historical lectures, particularly when I realize I know too many of the players who have made the changes in portal hypertension. But I'd like to take a walk through this. And I'm going to start with a bit of geography. You all know that this is Scotland, and this are two famous historical bits of Scotland, Hadrian's Wall, that really kept the Scots out. But much less known is the Antonine Wall that bridges across between Glasgow and Edinburgh. The Romans built this wall across there as they extended their northwest frontier in 142 AD. But I, as Will said, sort of trained in Edinburgh. And although these two cities are on opposite sides of the country, they're only 50 miles apart, and never the twain shall meet. However, at that time, it was as though there was a solid wall going north-south between the two. But as a senior resident in Edinburgh, there were 3 or 4 of us had heard about this guy in Glasgow called Les Blumgart, and he was doing some interesting things. So we snuck out one afternoon, went across. He used to give these seminars, and it certainly was an interesting stimulus to part of my career, because he was talking about things I just hadn't kind of seen at that point in time. So this was in about 1976, 1977. And really what he was talking about, the 2 things that struck me as we had this escape afternoon, I can't remember what we told our bosses we were doing, were 2 things. He talked to us about Dokgo pancreatography. As the surgeons who started this, the name has since changed, of course, to cholangio, and I was impressed. You know, we were in that era of you never quite knew if you'd left stones in the duct. Intravenous cholangiography wasn't that good. You sort of thought there was maybe something there. And here was a surgeon doing great new things to pull out the stones. And I think if you read the little bit there, you know, the average time to cannulate the duct was 10 minutes. You know, they were really pretty good, even in those early days with much less sophisticated equipment than you have nowadays. The second thing that hit me was liver resections. He talked about a series of liver resections, primarily for trauma. This paper was published the next year, a couple of years later, but really talking about liver resections. And I thought, wow, you know, you really can do this in the liver? And you think where we are now. But here, Les Blumgart was at it before many of us were at it there. And I think this was one of my stimuluses really to get into this overall field. So really, what did I learn from that visit? Les challenged the status quo. Everyone in this room who knows Les knows that. But I think that's something that all of us need to do and think about. Not just in our surgical practices, but kind of the current time with our healthcare reform, which is kind of where a lot of my career is going at the moment, challenging the status quo of how we practice and provide care, I think is important. And to innovate. I've shown you a couple of examples of where that struck home with me. And to study what you're going to do. If you're going to do something new, you've got to study it, and you need to prove and show that really there's some advantage to it. I'm not sure that we always do that as well as we could nowadays, and I think that's important. And then to publish and present. I vividly remember some of the Les Blumgart, John Terblanche interactions around things like cholangiocarcinoma, where they weren't exactly on the same page. Made a vivid impression on me as I completed my training in Edinburgh. Anyway, with that a little bit of background, let me talk a little bit about what for me in many ways is a personal journey, but really putting into context the evolution of therapies for portal hypertension, some of the current practice guidelines, and then summarize. So this is where my interest in portal hypertension started. This is the front of the old Edinburgh Royal Infirmary, no longer functional as such. They built a new one since I left. And this is the back of the old Edinburgh Royal Infirmary that looked out over the meadows in Edinburgh, wide open spaces of historic interest. You see the fence keeping the public out from the infirmary. And this is really where my journey started, in Ward 11 of the Royal Infirmary of Edinburgh, where my first case in 1976 was Mrs. McSweeney. She was a 56-year-old lady with primary biliary cirrhosis who had 3 major variceal bleeds. And we did an end-to-side portacaval shunt on this patient. So what really happened, and this was the guy who I was working with at the time, Mr. Archie McPherson, good Scottish name. He'd often wear his kilt. He actually became chief of the Clan McPherson in Scotland, so he's very into that. But he also played cricket for Scotland in his youth. So he actually told me as we finished that first case what would happen. We did this perfect operation. And his prediction, as we finished the case, was the patient would look excellent the first couple of post-operative days, that she would become increasingly somnolent over the next 3 or 4 days, that she would, about couple of weeks out, become jaundice and have progressive renal failure. Remember, our supportive care of these patients in the mid-70s wasn't that great, and she would die in a couple of weeks, and that's exactly what happened. So I thought, gee, you know, there must be a better way. And in many ways, that case just sits vividly in my memories from the mid-70s. So a little bit about Mr. McPherson, who really got me into this. Immediately after World War II, he had gone to New York, to Columbia Presbyterian, which was kind of the initiating powerhouse in portal hypertension surgery at that time. And he spent time there with Blakemore, a name that many of you have heard, and a Lord, who were really the 2 people driving the program there. And after he came back to Edinburgh, he had actually, by the time I was doing my residency, had a fairly extensive personal series with portacaval shunts, central splenorenal shunts, splenectomies, esophageal transections. And in my couple of years with him, before I went to Emory, I think I did all of these operations with him. And it really was my first teacher and mentor that got me interested in portal hypertension. A couple of papers. This was a paper from 1948 that he wrote shortly after he'd got back from Columbia Presbyterian on surgical approaches to portal hypertension. And the illustration there is of a central splenorenal shunt. You can see, in fact, the spleen and the kidney were both taken out, and an end-to-end anastomosis between the central splenic vein and the left renal vein. And the techniques actually are quite impressive. When you read these papers, they did these over Vitellium tubes, and really he had fairly good patency rates in this series. And then in my first paper in portal hypertension from those times in Edinburgh was beginning to look for other ways of managing some of these patients, where we did some transhepatic occlusions for bleeding varices. Now, these were percutaneous transhepatic. TIPS hadn't even been thought of at that point in time. And the second author there, Mike Buist, was a great interventional radiologist, but we used to sneak time, steal time in the evenings, weekends, to try and do something with these patients. It was a small series. It was 9 patients. I think a couple of them died. Most of them rebled. But you can see a couple of the pictures from that paper where that transhepatic cannulation of the left gastric vein, the big varices, occluding that, it was a learning experience. Let's leave it at that. So that kind of started me off on the journey to really think about the evolution of other therapies, surgical, endoscopic, pharmacologic, transplant, and radiologic. And really, I think the lessons learned are how do all of these come together. And at the end of it, too many decades later, really are patients better off? So let's walk quickly through that. So really from Edinburgh, at the end of our training there, we had the opportunities to do fellowships. And a lot of people came to the States for a year at that point in time. It so happened that my first opportunity came up in Atlanta. I had no idea where Atlanta was. Of course, I'd read Dean Warren's papers about selective decompression at that time. I had offers in the next few weeks from Boston and San Diego, and it so happened that I ended up going to Atlanta. I flew into Atlanta the end of June. The temperature was over 100 every day, humid. I thought I was going to die when we got there. But I was there from 78. Dr. Warren died in 89, and I left Emory in 92. And really, what I learned in this era, and I think some of the contribution to the changes, were two randomized trials done there. One comparing selective shunts, the Warren shunt, to total shunts, and the other comparing selective shunts to sclerotherapy. And I'm going to go into details on these, but in brief, the first trial was completed by the time I got to Emory, but the follow-up was ongoing. And this was the late follow-up of that trial presented in 1985. And really there was equivalent survival, and that's a very common theme for all the trials of portal hypertension, that survival never differed in any of the randomized trials, surgical, and even endoscopic trials. Other things are a little bit different. There was better control of bleeding with selective shunts, but that's probably because the total shunt chosen in that trial were the interposition shunts. Some of them with grafts, some of them with veins, and there was a thrombosis rate there. There was a lower encephalopathy rate with the distal shunt, but it was marginal. And then there were a lot of metabolic studies done around that trial. The second trial, which we did, and that I had ran a lot of it, was comparing endoscopic sclerotherapy to distal splenorenal shunt. And this study showed, and I think helped shape the changing face of how patients were managed, that starting with sclerotherapy, with surgical rescue for the 33% of patients who failed sclerotherapy, provided a better outcome than going directly to distal splenorenal shunt. Now, this is a spectrum of Child's A, B, and C patients. Yes, the selective shunt had better control of bleeding. The encephalopathy rates were the same, and I think that was an important piece of data for the distal shunt to show you weren't accelerating encephalopathy. But it didn't, certainly in our mind and experience, established start with sclerotherapy and just reserve surgery or decompression for those who rebleed through it. Because with sclerotherapy at that point, and banding really wasn't in yet when we did this trial, bleeding was controlled in 2/3 of the patients. So really from that surgical bit, then really you get into the endoscopic era. And remember, really it was surgeons that started the sclerotherapy for esophageal varices. John Tablanche and Carl Paquet really were the two who, starting with rigid scopes, moved us to flexible scopes. And certainly when I was at Emory, we, the surgeons, did the sclerotherapy, but it was that tiny little image at the end of a tube long before the video screens became available. And the gastroenterologists thought we were crazy sticking needles into these big veins, more or less blindly at the end of those scopes at that era. But gradually the technology evolved to much better vision, and the gastroenterologist took it over. And there's another surgeon, Greg Stigma, I don't know if Greg's here or not, who had done a lot of banding of those veins at the other end of the track, hemorrhoids, and thought, why aren't we just banding the ones at the top end of the track? And really instituted banding for esophageal varices. Initially, that was cumbersome. You stuck something on the end of your thing, single shot releases. It wasn't easy, but technology soon caught up with that for the multi-band ligators. And it moved from surgeons to the gastroenterologists. There are multiple trials, the results gradually getting better, banding be better than sclerotherapy, and advantage to patients. The next era really that sort of came along chronologically in my book really was the pharmacologic era, and this is the person who really put that on the map, Didier Lebrec from Paris. And this was around 1980. And I vividly remember his first visit to Emory. Dr. Ward, we used to have a Friday afternoon conference where we went over all the patients of the week. And if there were visitors, they'd give a talk there. And Dr. Didier gave this talk about it. And Dr. Warren just laughed him out of town. He says, there is no way you're going to control and manage variceal bleeding with drugs. Well, Dr. Warren was wrong. You know, it is part of the repertoire. You don't totally control it, but clearly, I think the important thing I saw in this era was that it really heralded a whole new era for investigation of the pathophysiology of portal hypertension. There are a lot of studies done in that era that really spelled out the hemodynamic changes of the cirrhotic patient. It's not just about the portal hypertension, it's about the systemic hemodynamic changes as well, the hyperdynamic circulations, how all the bits tie together. And really, I think the early 80s was the stimulus for this. And multiple clinical trials demonstrate benefit for prophylaxis with beta blockers, and reducing rebleeding rates in those who have bled. And clearly they remain an established part of the overall management of these patients. And of course, transplant. The role of transplant in variceal bleeding really was dictated again by the establishment of transplant as an available treatment and the growing expertise across the country and across the world. And really that was happening through the 80s into the 90s. I think establishing its role in managing patients with variceal bleeding was always a little controversial. I think there was a phase where patients with variceal bleeding were probably getting transplanted when they still had pretty good liver function. I think that we've kind of moved through that era, because really it's the end-stage liver disease that is important. So decompression of varices and treats the underlying liver disease. And certainly remember that this is the one treatment that significantly altered the outcome for patients with Child's Class C cirrhosis with more advanced disease. Downsides, of course, being immunosuppression, but as we all know, that's got better and better. And then it really comes down to the appropriate selection criteria and then the timing of when should these patients be transplanted. But variceal bleeding per se is not always an indication of end-stage liver disease. It can be. Finally, kind of the final era is the radiologic era. Now, there are many names I could have put up here rather than picking one or two. I think this evolved over time from initially just punching holes through the liver, dilating a tract, not putting anything in there, some blood flowing for a bit, but not great results, then into the bare stents, and then finally into the coated stents, with rapid evolution really through the 90s, and a lot of clinical studies and widespread adoption. And then there are some randomized trials in that. I'm going to focus a little bit on the third randomized trial I was involved in, which was selective shunt versus TIPS for Child's Class A and B patients with refractory bleeding. This was an NIH-funded trial with 6 centers involved. So the randomization was for one of the two procedures, the operative selective shunt maintaining portal flow, and TIPS, which is a total shunt and really diverts all portal flow. This study entered 140 patients. They were Child's A-B. By this time, and this really was into the mid-1990s, Child C patients really were not candidates for surgical shunts by that era. And you can see the break of alcoholic, non-alcoholic disease patients entered into this study. This follow-up was basically about 5 years. There was a tail to it. Recruitment was good early on. As it became apparent where TIPS was going, it kind of tailed off laterally. So most of the patients were 5 years out when we closed the study. Here is a synopsis of the results. The 5-year survival was not significantly different. Rebleeding was not significantly different, although it was a little higher in the TIPS group. The encephalopathy rates by 5 years were the same, and the one thing that was different was the reintervention rate. And this was done, remember, in an era when covered stents hadn't got on the market, so this was done with bare metal stents. As I said there. Here's the survival curve for that trial. The dotted line on the top is the tips. I was blinded to this, and as my data safety monitoring board said, we've got to keep going, got to keep going. I thought, and you can see why. It looks like the lines were separating around the 3-year mark there. The tips actually was perhaps heading in a better direction than shunt, but they came together by the 5 years. And I think the other point of emphasis on that is, remember, this is an era when transplants were having kind of 60, 70% 5-year survival rates too. So here you got patients with variceal bleeding managed with either of these with a 60% 5-year survival rate. And I think that was an important further piece of information from this study. The encephalopathy, again, paralleled right across here. Initially, tips at a slightly higher encephalopathy rate, but then really the lines parallel right out there. And this was any episode of encephalopathy. This is not incapacitating. Anything that needed any change in treatment got counted in this group, and these were independently reviewed within this study. There was a central repository for review of these events in an independent way. Another important part of this was the cost effectiveness analysis in this particular study. And at the average yearly costs were not significantly different. It was, by 5 years, it was slightly less in the distal shunt group than the TIPS group, and obviously that's because of the reinterventions. The cost effectiveness analysis for those aficionados of cost effectiveness analyses did show that at 5 years, TIPS was moderately cost effective. So despite the reinterventions, when you started taking consideration all the readmissions, within this study, only 7 patients came to transplant overall. So it wasn't as though we're getting deep into that. It wasn't that this was a cost-ineffective way of managing patients. So this, again, is widely touted as further support for using TIPS. As not a study I was involved in, but I respect the multiple studies the Europeans do, and this was one done around that time that when the covered TIPS stents first came out, and they clearly showed that dysfunction was significantly lower with covered stents. And clearly, by the time we finished our randomized trial, that was where the field had gone. So when you think about portal hypertension, when I started studying, variceal bleeding was the big thing. And that's what patients were dying from. As we got better and better at managing, controlling that, some of these other complications really started to come into play. Ascites, HCC, a lot of this meetings around HCC. Some of the lung syndromes were very interesting in the portal hypertension patients. And then obviously liver failure. Let me just grow up. Sorry about that. But the common theme really with these, as for some of the patients with variceal bleeding, was are you dealing with decompensated or advanced disease? And certainly for these, you're talking about, thinking about palliative therapy or transplant. So really, you can't talk about portal hypertension without talking a little bit about transplant and where does it fit into this journey? Obviously, starting with our cadaveric transplants, and then I'm not going to get into detail about living donor transplant. Had some experience in that space. Those were my most terrifying days in the operating room, I think. It's always scary when you're taking someone who's totally normal and taking out half of their liver. But there are no randomized trials for transplant portal hypertension, and there won't be. So it's how do you fit that into this total scheme of things? And I think really my view of liver transplant portal hypertension is going from the theory, the transplant is the best treatment for portal hypertension, and it's the only treatment, as I said, that has improved the long-term outcome of patients with decompensated advanced disease and variceal bleeding, and you could argue also for the other complications of portal hypertension I showed, to the practice. There are some limitations to transplant. The availability, the candidacy, the expertise, some of the complications of transplant. So really hitting where does this fit in, what are the overall recommendations, I think is important. I think transplant is certainly one of the options. It's not, in my opinion, the total answer for everyone. And indeed, in the right patients, you're getting increasingly remarkably good outcomes. And I think those survival curves have risen progressively. Depending where you are and what you're doing, defining its place in your program is, I think, the key to how it fits into managing patients with portal hypertension. So really, as I look at what I have seen over these few decades, I think the management options really have evolved. When I think back how little we were able to do in the 70s, really when I started, although there was, as I point out with Mr. McPherson, quite a few options available, you've also got to put this in the context of the overall patient management, which has got so much better. You think about the overall fluid management of these patients when they bleed. I think we used to drown a lot of these patients, over-transfuse these patients. So the overall fluid management of the cirrhotic, the use of antibiotics with the variceal bleeder, we didn't do that 3 or 4 decades ago to prevent complications, and really about developing the team. This isn't something that is owned by a surgeon, a gastroenterologist, or radiologist. Truly, you need a multidisciplinary team who assess the patient and have some standards of practice, some guidelines, if you like, some checklists you follow through as you manage this group of patients. One of the risks in that is who's in charge. And again, I think clarity and definition. Now I'm beginning to wear my hat of what I do now, quality and patient safety, where communication and who's in charge of patients is one of the biggest issues. So I think these are where some of the current opportunities really sit, is thinking about how is your team structured and who really is managing these patients, because that's how you improve outcomes. So given that, the sort of overall current guidelines, I briefly summarize here. On the left are some of the European work that has come out of the European groups who do work very well together across countries there in establishing guidelines. And then the practice guidelines from the AASLD here in the States. And really, they are virtually identical. You know, prophylaxis is with beta blocker. And in some of the higher risk patients with big varices, even if they haven't bled, with prophylactic banding. So Dr. Warren Didier-Lebrecq was right, I do believe. The acute bleeding, again, that's managing the patient is the key bit to this. It's about the appropriate resuscitation. It's about the other things you can do to lessen the risk of complications. And yes, it's some of the drugs that are available to reduce portal hypertension. It is about endoscopic therapy. And perhaps in some of the higher risk patients, it's about early tips. And there's one study I'll reference that supports that. And then with rebleeding, really initial treatment, I think, is with beta blockers and ligation. Tips and distal shunt, I think I've just shown you the data that says really tips. And then if you've got end-stage disease, going on to transplant. Again, this is a recent about 2-3 years ago, update on the practice guidelines from AASLD on where TIPS fits in, and clearly with covered stents. They clearly quote the trial I showed you in terms of as effective as distal shunt, and really much more widely available, cost-effective at 5 years. I told you they'd use that data sitting out there. And they also endorse its use in some patients with Budd-Chiari syndrome with an acute event and ongoing liver damage. This trial just came out this past year from the multi-European study using TIPS for high-risk in the acute setting for high-risk bleeding. And they entered 75 patients with a 14-month follow-up and clearly had significantly better control of bleeding and marginal to significance in improving survival in this group of patients. This has been kind of on and off again for a little while, But I do think I pulled this in because I think it does support use of TIPS in some of the refractory acute bleeders who are high-risk patients early on. And it may well be a bridge to transplant for them. And frankly, I think this is what happens in practice in most places at the moment anyway. Finally, I always have to quote this paper from Hector Orozco and Miguel Mercado. It's actually one of my favorite papers in portal hypertension, and Hector, as I think many in the audience know, died about 6 months ago, was one of my other favorite people in portal hypertension because he worked with all the available therapies. But this editorial in the Archives of Surgery in 2007 kind of summarized it up, that we'd spent 25 years developing optimal operations. We really did define who benefited from what, and really by the 2007 we wrote this, the operative mortality for those that we chose to operate on was low. Bleeding control is excellent. And really, I think bleeding control, different studies, different procedures, different expertise in different places in the world could achieve good results with relatively low encephalopathy rates and increasingly good 5-year survival. But this, remember, had become progressively more selective in the patients we chose to operate on. And again, a picture of Hector and Miguel. This is looking out over the scene from where Hector retired to, and I always felt that this kind of summarized it a bit. I know Hector, to his dying day, felt we should operate on these patients rather than do TIPS in them. But Miguel, who's sitting in the audience here, I think we are in a more balanced place at this point in time. So really, in summary, I would say that to me, the most important thing is the overall general management of patients, these sick liver patients, really has improved enormously. I think that's probably the biggest contribution over these last few decades. The new specific therapies that I have run through clearly have defined roles. There's never has been or will be a one-size-fits-all here. There is a role for pharmacologic therapy. Clearly, endoscopic is established as one of the major treatment options. The surgical approaches, there are some patients who can benefit from any of the things I have shown you, but they're got pretty small. Clearly, the biggest surgical thing sitting there is transplant at the present time, because we can manage these patients through to that point in their disease, usually with things short of surgical therapy. As I conclude this, I really think patients are a whole lot better off than the patient I started this with, Mrs. McSweeney, back in 1976. Certainly, I view that case was a stimulus to my interest in this. But as I look at the people I have shown you have advanced this field, I have the privilege of knowing and meeting many of these people as these things evolved. It's all about the patients at the end of the day. So though Les isn't here, Les Blumgart, as I go back to my beginning, I think no matter what your field is, it's about the patients. Keep that number one. It's about looking for new ways, but it's about proving the place of those treatments as you develop new approaches and new ideas. Don't be satisfied just with doing them because you can do them. Prove that there's a reason for doing them and that it really does benefit your patients, not just you. So Les, thanks for helping me start my journey. That was a long time ago that I crossed the wall between Edinburgh and Glasgow, but clearly I think that was a stimulus to helping me think about some of the things that have been an important part of my career. I just appreciate the opportunity of giving you this personal view and journey through certainly what I think has been fun for me, and watching and looking at this group and this association has been one of the other very rewarding bits of my career. Because I can tell you, when we started in 1995, Henry, Bill, and I were wondering if there'd ever be a second meeting, and look at it now. So thank you all very much. I appreciate the opportunity to talk to you today.